With our last live show of the season, we end where we began. It's our viewers' favorite show topic, Ask Anything, tonight on Call with the Prairie Doc. 21 seasons of providing health information based on science, built on trust. Hello and welcome to On Call with the Prairie Doc. I'm Dr. Andrew Ellsworth, tonight's Prairie Doc host. Thank you for joining us during our 21st season, providing health information based on science, built on trust. During our last live episode tonight, we will be answering viewer questions about any medical topic, your questions. Joining us tonight on the campus of South Dakota State University are family medicine physicians Dr. Scott Boyens with Sanford Health and Dr. Shelby Eischens with Avera Health. Welcome, Dr. Boyens, Dr. Eischens.
Thank you.
Come here.
So, Shelby, if you would, please tell us a little bit about yourself.
Yeah, so I'm Dr. Shelby Eischens. I practice at Avera here in Brookings. I've been at Avera here for 12 and a half years. I did practice in Minnesota for almost 5, so I'm a South Dakota transplant. I practice general family medicine from newborns up to end of life. I do a little hospital work too, so you know, if you're in the local hospital, you might see me there too. Yeah, just bread and butter family medicine.
Awesome. Good to have you here in Brookings. How about you, Scott?
Yeah, Dr. Scott Boyens. I've been a family doc here at Sanford in Sioux Falls for almost 25 years. Sioux Falls kid, pretty much. And so I've enjoyed being a part of that community throughout the years. Do a lot of just general family medicine, don't deliver babies anymore, but and miss it, but spend a lot of that extra time doing primary care sports medicine for Augustana. So it takes a little time there.
Sure. Mm-hmm. Excellent. So all the sports do you help out with? Or?
All of them. Yep.
Nice. And excited for hockey.
Yeah, I'm excited for hockey.
Sounds good. Well, before we start our conversation, we invite you, our audience, to submit your questions. Viewers can contact us 3 ways. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. To encourage you to ask early, all questions asked in the first 20 minutes will be entered into a drawing for one of our Prairie Doc gift items. The winner will be announced at the end of this program. Your question will remain anonymous, but please provide contact information when you submit your question. So we had a question starting right off from an email. This person says, I have several keratoses, patches, minor, on my forehead and ears. My doctor has treated them twice with nitrogen freezing. Lesions peeled off but returned. Should I repeat nitrogen or try another treatment? Topicals? Comments on the eventual cancer concern. I have no cosmetic concerns. I'm grumpy old 76-year-old anyhow. White male, Northern European type. What do you have to say about that, Shelby?
So with keratoses, you gotta differentiate. Is it seborrheic keratoses, which are completely benign? And really, those things, you really don't have to do anything more or anything for them. They're purely cosmetic. I know some people really don't like all those plaques everywhere. And yes, we do treat them with that freezing nitrous treatment, and they can go away, but they can come back. That's the bummer about them.
Okay. Those ones that are kind of have that stuck-on appearance.
It looks like a scab, and sometimes actually you can catch them and they can flake off. But yeah, those ones are not a concern. The ones that are a concern are the actinic keratoses, and those can be potentially precancerous, and those are the ones that you will want to treat. You can try the cryotherapy with that. Sometimes there's other treatments, but those are the ones that you should follow with your doctor if it doesn't go away after a treatment.
Yeah. So, Scott, how can they tell if maybe it's one of these precancerous actinic keratoses?
Yeah, usually those are a lot of times they're on sun-exposed areas for the most part, ears, foreheads, scalps with no hair, hair, forearms, wherever, and they're usually flat, red, and a little scaly. But I will treat those, and if they seem like they go away but they come back, I usually get a little bit more aggressive and say, hey, is this truly an actinic keratosis? Because you start, getting things on the ears and stuff. That may be an early superficial skin cancer. So that's one way I go with that. The other way is if you've got a lot of actinic keratoses on the scalp, some of the, the 76-year-old grumpy old man, whatever, the dermatologist may go a little bit more aggressive and kind of do a peel of that skin to get those just to go away. There's too many to freeze at times. So
where they use a cream, and then it lights up, and there's red spots all over. But then it usually gets better that way.
Yeah.
Any problem with freezing an area more than once?
Fine.
Not usually. I think there's a little bit higher risk of scarring maybe in terms of, that area becoming really light pigmented so you can see it, or in certain cultures and skin types it can be hyper pigmented where it's darker skin so it looks like a scar. But otherwise, I usually don't try to treat them more than a couple times at the most if it's those seborrheic keratoses.
I kind of give them 3 strikes.
Yes.
Do it once, maybe we'll do it again, but a third time, I might do a biopsy, shave it off, or, But you can treat an early cancer with freezing sometimes too, but not a melanoma.
No, melanomas are a different ball game, and those ones you need to see a dermatologist. They need to be excised. They need to check for other things because melanomas can spread throughout your body, and those are not great ones to have on.
They're usually dark and irregular and really dark in color. Mm-hmm. Anything growing or changing, you should get checked out, right?
Yes.
Exactly.
Yes.
Now we've got a bunch of questions all of a sudden now. Let's switch to cardiology, Scott. What are treatments for AFib? What is AFib?
Well, atrial fibrillation, it's a condition where the top chambers, the atriums, are kind of doing their own thing, and the bottom chambers are kind of pumping at their own rate. Okay, and it's just not a very effective it's just not very efficient pump when it's doing that. And so things have changed with atrial fibrillation over the years. It used to be when I was early on in practice, we did everything in our power to get somebody out of atrial fibrillation, everything. And we've learned with studies that mortality isn't necessarily increased now if you can tolerate atrial fibrillation. So there's some that can't, some that can.
Yeah, some get tired.
Some just can't
their heart
stand
racing,
it,
and some don't notice it.
They don't notice it at all. And so as long as you control the rate, they're fine. But there's all kinds of treatments. Medication is usually what's done first, and we can shock them out of atrial fibrillation. We can. I can't, but there will be people that do. There's ablations that you can do for atrial fibrillation. Some people, if they really can't tolerate it, will have pacemakers for that too. So there's a lot of options and a lot of different medicines too.
Mm-hmm.
You mentioned rate, so a medication to help keep it slower so it doesn't get too fast and out of control. And then anticoagulation. Shelby, what is that? Why do we do that?
So one of the risks with atrial fibrillation when your heart isn't pumping regularly is it can build up clots. Well, what's the bad thing with clots in your heart? It can go to your brain, increase your risk of strokes. So a lot of times with atrial fibrillation, we usually recommend an anticoagulation therapy. Now, there's certain patients that we need have a higher risk of that, and that we're more aggressive with that. But sometimes, some patients, if it's paradoxal or they know when they're going into it and when they're not, sometimes they just get by with aspirin, but that's not very common.
So typically a blood thinner such as good old Coumadin, warfarin, or rat poison, or some of the newer ones, which are easier but can be expensive.
And you weigh do you want to always check your blood thinness, with the INRs if you're on Coumadin versus not having to with the Eliquis or Xareltos or those other newer ones. Kind of the new thing that a lot of patients are asking me about now is the Watchman. And that's that little parachute thing that they can put in one of the atria where the clots seem to form the most common place. And so if they can kind of close that part off of the heart, then they can sometimes get off some of the anticoagulation.
And I'd recommend a previous Prairie Doc show on cardiology to get more information on some of those options. This person says, I've had many diverticulitis flare-ups over the last year, and I'm wondering what surgical options there are to help with this. What do you say for those that have multiple diverticulitis flares?
So, I guess if you have recurrent diverticulitis, probably your best bet is to talk with a gastroenterologist or a general surgeon to see if that would be an option. Obviously, we don't try to do surgery if we don't have to, especially with a colon resection, which is probably what's going to happen, just because it's a major surgery. And what age are you? What risk factors do you have for surgery? But, I have a patient right now who's going to have surgery because, she's developed other complications from her diverticulitis. She's got abscesses or she has had abscesses and has developed a fistula now. For the most part, we try to treat medically, but yes, if it is recurrent or, depending on how frequent, that might be a consideration.
Can diet help, Scott?
Well, yeah, it depends. Anytime you've got the diverticular disease or diverticulosis, those little outpouchings off the side of the colon, one of the diet recommendations will be to avoid seeds or strawberries, sesame seeds, sunflower seeds, different things that could get caught up in those little outpouchings to maybe be a nidus for the diverticulitis to take off. It seems like the younger folks that get diverticulitis are the ones that are going to end up with surgery. It has to do with, I believe, if it happened at 35, it's bound to happen again and again and again. And so the surgeons seem to be a little more aggressive at just taking care of it then. As you get older, it's kind of hands off a little bit and let's see what happens and hopefully no complications develop from it at that point.
Now, supposedly, seeds and popcorn and everything else don't matter with it, but we all know patients that they found that's what triggered it too.
Exactly. Exactly.
But they don't want to give it up, though, either.
Can headaches also cause your teeth to hurt? Any correlation there with headaches? When you think about causes of headaches or causes of teeth, even think about kids and ears, and sometimes they're teething and they get an earache. So can headaches also cause your teeth to hurt?
I'd probably just head towards, the sinus headaches or whatever those might be. You hear people talk about those all the time, and I have never defined that exactly. But that's kind of in there. I think about, your chewing muscles being in tension and all that.
Causing a headache.
Yeah, kind of
more vice versa. The source might be
exactly more tension type stuff and what's going on with all of the teeth grinding. I suppose
the people who tend to tense have a lot of tension in their jaw. Probably, that's more of a muscular thing, which all those muscles interact with the jaw and the face muscles. So that's another thing I would think of. Yeah. Probably
worth seeing their doctor and trying to see if there's something going on or a cause or what can we do to help. Yeah. Can we talk about shingles? When to get a vaccine and the side effects of the vaccine, Scott?
Now, the shingles vaccine is recommended age 50. And a lot of people have had the first one that came out, the first iteration of it, but now there's the new one, and that's a two-shot series. But it's no longer a live virus. But there still seems to be a lot of folks that have that immune response after a shingles vaccine. They get the body aches and maybe a little fever, and they just don't feel good. And in my eyes, that's actually a good thing, because their body knows how to fight that virus now. You're telling me that you know how to do it, but it doesn't feel very good when you're in the midst of that kind of reaction that they complain about. It's usually short-lived.
Are you finding Medicare is covering it now?
Yes, it's better after the first of the year. It's not still free, but it's better than it was. Yeah.
2 shots, 2 to 6 months apart.
Yeah, and it's good.
Yeah. I usually tell patients, just as a side note, 1 day of feeling yucky is far better than almost 2 weeks of pain and itching, and it's the pain that really gets them with shingles. It's unbearable sometimes.
And especially those cases where the pain lasts indefinitely. It'd be nice to prevent that in the first place. Hope Haven's Chairs of Hope is a volunteer group that helps restore wheelchairs to nearly new condition, then delivers them throughout the world. Prairie Doc reporter Sam Schauer tells us more about their ministry.
John McComb is a volunteer for Chairs of Hope. Its mission is to fix old wheelchairs and refurbish them for people in other countries that can't get a wheelchair.
They decided there was a need for refurbished wheelchairs for individuals in third world countries, and they got going and started it up, and they've distributed a lot of wheelchairs since then.
A lot of wheelchairs indeed, with over 6,000 wheelchairs refurbished and donated in their shop alone outside of Brookings, with help from many other volunteers.
So we've had as many as like 7 or 8 people at a time working here at this shop.
McComb says they received the old wheelchairs from all over the country from their partner Hope Haven.
And they collect these chairs from all over the country. I'm not sure how they find out about them, but they do. And then they distribute them to us and the various other shops.
A typical day for them can go something like this.
Oftentimes we have to replace the arm pad here because they're frequently broken or cracked or ripped. This one actually looks pretty good. So if I take the bolt and nut off, then I can get to the bearings, extract the bearings, check if they're good. This one's pretty stiff, doesn't really work, and it doesn't really hold the tire very good either. And so it just comes off like that.
This one should fit 18 by 16.
And that's that.
And he says all of that, plus rebuilding, takes around 3 hours for one chair. But each chair they revamped has been donated to over 100 countries.
They've gone to countries like Guatemala, Mexico, Vietnam, lots of different countries.
McComb also says wheelchairs are in constant demand and need volunteer help for all their shops.
We're looking for several people who would like to join us. Mechanical skill is not required.
What a great program, the ministry. And I understand you have a connection with that.
I do. Hope Haven is in Sioux Falls, and the Sioux Falls Rotary Club on the west side has been involved with that organization for quite a while, and my dad's a big part of that. And as he and my mom have both been to Romania to deliver some of those wheelchairs to those folks that need them, and it's been a wonderful experience, a wonderful ministry for both my folks and the people that they've been able to serve through Rotary.
Yeah. So if you're recently retired or looking to volunteer, I bet they could use some help there in Sioux Falls or Brookings or other places. It's a great program. We've got a lot of questions, but we'll try to zip through some of these. This person says, I'm hearing a lot about Ozempic in the news. What is this for, and is it safe? What would you say about that, Shelby?
So Ozempic is technically a diabetes medication. And it's a really good medication to help with diabetes management. I think the biggest thing that's come in the news lately is it's also good for weight loss. And so a lot of people are wanting it for weight loss. And people are losing weight with it. But that's not the primary goal of the medicine. The medicine is marketed for diabetes.
How does it help with either one, diabetes or weight loss?
So, correct me if I'm wrong.
Yeah.
It works on the hormones in your body that help with your appetite. So it can decrease your appetite. It also works to block different receptors that help with your body working with insulin. Like a lot of the other diabetes medicines, it's just in a different mechanism. But one of the biggest things is it does help suppress your appetite.
Yeah, and I'm sure we've all seen it help patients.
Tremendously, but it is expensive.
Right.
That's
right.
the downfall.
Yeah.
How much are we talking?
Expensive. Well, it can be $1,000 a month, depending on what the coverage is like, if it's even there. It does work, and it works well. Are you going to stay on it? Because as soon as you come off it, the weight will come back. Which a lot of diets are that way. And so hopefully if you're on it and it's working, hopefully you can take some of those lifestyle changes that you've made to carry you then through if you do end up stopping the medicine. So there's many conversations between healthcare providers and the payers that are.
That's the other question. Will insurance cover it?
It's variable, and they're running the numbers and trying to see who's going to stay on it long term. Is it worth it for them to cover it or not? And hopefully it is, because it does help a lot of folks, and there's quite a few options now there. So
yeah, certainly covered better for diabetes.
Yeah, but still expensive for our diabetics too.
Right. Right.
But yes, covered much better for diabetics. I don't think it's covered at all for weight loss, at least as of January 1st. But
yeah, and of course, we've all seen patients that hunker down with diet and exercise and had even better results than any medicine.
yes, it's all about balance and just having your goal of this is what I need to do. I've seen it in my practice time and time again. Is it hard? It is very hard to get on that treadmill every day, to watch your portion sizes on your plate, to eat more vegetables and less candy bars, drink less pop and more water. But the goals in the long run far outweigh any medication you can take. It can help control your blood pressure, it can control your sugars, it can control your cholesterol, all of those lifestyle choices.
You guys have both been practicing medicine long before any of these newer medications. What are some ways you've helped patients achieve some of those goals with their weight or blood pressure or anything that where lifestyle helps?
Yeah, if there isn't one, good diet program that will help somebody or help everybody, and so when I look for programs for patients to recommend, I'm looking for something where there's a little bit of accountability. Who's watching? Who are you accountable to? Who do you have to report that? Yeah, I had that candy bar and I shouldn't have, type of thing. It just helps. Is there a program that will help eat right? Because as much as exercise is good for us, you can lose weight and not exercise for a minute. If you do it correctly, it helps. You make it better if you throw exercise on top of that. But it's been a struggle for a lot of folks to deal with that weight issue, and with what we have available to us in our foods and it's just hard to overcome some of that processed stuff. So,
Food is always right there, right? Mm-hmm. You go to the gas station, you go pay your gas bill, which I pay at the pump. But nonetheless, there's the advertisements, right, at the pump.
And on TV all
Yes.
the time.
Your candy bars are 2 for $4 today. Your pop is 2 for $4 today. I mean, and the convenience stores are crazy, like in terms of all the bad processed food choices. So it's always right there. You go out to eat and your portion sizes are 3 times what you should be.
Yeah.
So it's really hard to get around it. I think you just kind of have to like set your mind to, I don't want to do that because this is my goal. Is it easy? No. But you know, the more you set your mind to it and kind of remind yourself this is my goal, it makes it a little easier.
Yeah. Yeah. You know, in planning ahead.
Exactly.
And having shared meals and planning your lunches and if you're gonna eat out, well, avoid eating out probably, but if you're gonna eat out, split it in half, split it in thirds, and put that in a takeaway, and here's what I'm having.
Yeah.
Because us South Dakotans, we want to finish our plate, right?
Yeah.
And we want to get our money's worth
We want
at the buffet.
yeah, a buffet is probably not a good idea either.
Yeah.
But,
Or even sitting at your table. I mean, what do? We put everything right in front of us, right? Well, one of the keys I tell my patients, keep it in the kitchen. That way you have to physically get up and get that second portion. It makes you less likely to just take another bite and just take another bite and just take another bite.
Yeah.
So.
Yeah. Out of sight, out of mind helps.
Exactly.
This could be a short answer. Do they know of any new studies that have been developed for dementia in Sioux Falls? Do you know of anything that's going on in Sioux Falls for dementia?
No, it's, you know, we're trying in the Sanford system. We're trying to work with our genetics folks and trying to get that piece going. But the genetics around dementia and predicting dementia is still not there, which a lot of people are waiting for.
Yeah, yeah. Can you recommend a cream for someone who is allergic to rubbing alcohol? You know, in general, what creams do you recommend for people for skin care?
So moisturizing is probably priority, and a good moisturizer. Like CeraVe is one of my favorites. Vanna cream is a really good one. I think those ones without the perfumes that are a little richer are probably your best bet. And moisturizing goes a long way, whether you have psoriasis or eczema. It's like the number one thing I tell patients about. And then staying away from perfumes, like perfume lotions, staying away from perfumed body soaps, those fancy things that you get at Bath & Body. They smell great, but they might be very irritating to your skin because of their perfumes in it. So.
And we're not always meant to shower every single day.
Exactly.
Or a long hot shower might not be the best for your skin either.
Right,
So,
right.
Yeah. This caller has suffered from chronic lower leg pain, has had multiple tests done. She's even seen an orthopedist for the pain and nothing helped. She was curious what could cause her problem. What do you say for people with chronic leg pain?
Wow. There's a lot there, and it kind of depends on where it is and where it's coming from as far as the signs and symptoms. But, you know, I kind of break it down. You know, you've got your vascular supply, you got your nerve supply, you've got your muscles, you've got, you know, the low back and how that feeds down into the lower legs, and so it's a matter of just kind of checking off each box and trying to figure out what their symptoms are like. What do they get better with? What makes it worse? You know, how all that symptom stuff that comes out while you're talking to a patient, or even listening to the patient tell you what's going on, a lot of times tells you which way to go first, or at least try first.
Mm-hmm.
Yeah. Yeah, she mentioned seeing an orthopedist, but there's so many other avenues there. So I think, you know, going to your primary care doc and saying,
where do I start? I mean, that's
Exactly,
and I might not be
exactly.
right, but I'll get there eventually. It might take a while.
Yeah, yeah. Sometimes it's, you know, if it's not this, well then maybe it's this. So yeah, I think starting with your primary care doctor Because yeah, getting that history is like the biggest benefit for trying to figure out, like you said, where to start.
Yeah. With summer just around the corner, it's time for outdoor activities to begin. Many of us enjoy water sports, so it's prime time to refresh ourselves on CPR basics and any revisions there may be to the life-saving technique. Here's Prairie Doc's Sam Shower.
Are you okay? Help! Somebody, call for help!
Wendy Long is a paramedic for Brookings Health System, and she oversees the training of CPR. She says the first rule is to make sure you're safe and call the EMTs, then proceed with CPR.
6, 7, 8. Always check with your 2 fingers, never your thumb. Your thumb can find your own pulse, and then all of a sudden it's a good day, and it's really not. So check with 2 fingers on the side closest to you in the carotid artery, so just right underneath the jawbone here. You're going to check for 5 seconds, no more than 10. If you don't feel a pulse, or if you're not sure you feel a pulse, you're going to start CPR.
She says the biggest change in CPR is the beats per minute when giving chest compressions.
So your rate's going to be 100 to 120 beats a minute. It used to be a little bit faster, it used to be a little slower. Now studies show that 100 to 120 beats a minute is exactly where we need to be.
Long says to press the chest down around 2 inches and let it fully recoil back up. She also says the sooner chest compressions start, the better chance the person will still be alive.
For every minute that somebody goes without CPR, it's about 10% of your brain. So if you do the math, after 10 minutes, you're probably going to have no brain activity.
And if you're having trouble finding the tempo, Long says to remember these songs.
So if you're optimistic, you can be staying alive, or that's why I'm a medic, not a singer. You can do Another One Bites the Dust if you're not quite as optimistic. Or if you are like the kids in my babysitter class, say, we don't know the words to those songs. Baby Shark will also work. Baby Shark, do, 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 do.
The other big change is rescue breaths.
So that is once every 6 seconds for an adult and once every 2 to 3 seconds for a child. However, if you're not trained in delivering rescue breaths, you can just do hands-only, high-quality CPR and get a good result.
Good tips to remember are finding a hard surface,
The ground is the most readily hard surface available.
keeping your shoulders over the person,
If you see, my shoulders are not directly over the patient. If I'm pressing down, I can possibly break ribs and they can become displaced. And if I'm pressing at an angle, I could accidentally puncture or rupture something that should not be ruptured or punctured.
and doing chest compressions on the lowest part of the breastbone.
We want to avoid what's called the xiphoid process. This is a V here. There's a little bone that floats here. We can accidentally break that off and also puncture things that should not be punctured.
Very important life-saving technique. And if someone's worried about puncturing anything with doing CPR, should they?
Just do the CPR.
Just do the CPR.
Yeah.
Right.
Yep.
Exactly. Very important. We can worry about any of that other stuff later. But
Exactly.
we got to get their heart going and
Exactly.
get that blood flowing to the brain.
Yep.
With apparently Baby Shark. I don't know. That's beyond our time, I guess.
Yes, yes. My kids are too old. I don't know the Baby Shark song. I have a lot of kids that come in and sing the Baby Shark song, but I can't sing it with them anymore.
We're going to go quicker through these. We got a lot to cover here. She has a white spot on her lower lip that she thinks might be getting bigger. Should she have it biopsied?
You should probably go see your primary care provider and see what they think it is, because it might be a scar. It might be, I mean, any other number of things. It could be a benign thing. It could be, it could be something more serious. So start with your primary care provider, have them look at it. If they do feel like it's something that needs biopsy, they might be able to do it, or they can send you to a dermatologist to have that done as well.
Excellent, excellent. Yeah, but bottom line, if it is changing, probably better get it looked at, or if you're unsure about it. This says, what are the doctor's opinions on acupuncture? Scott, what are your...
I'd love to try it sometime. There's something there. I can't explain it. I can't. But if given given the chance, or if I ever am active enough to have an injury that would maybe benefit, I'd love to try it, because it's one of those things that's so, it's just lasted so long through history that there's got to be more than just placebo, more than just kind of heal thyself, but maybe.
Yeah, I mean, there's more. We're not limited to Western medicine necessarily. There's
Right.
there's wisdom
Right.
from around the world that
Right.
we can use. This person says, I have a tremor or a shake in my left thumb only. If it is worse if I'm holding something, no other tremors anywhere, will be 69. What kinds of thoughts could cause this?
I'm jumping probably first to more of a familial essential type tremor rather than Parkinson's. I mean, that's what most people want to come in and want to worry about. And so those intention tremors, I call them, where you try to do something more fine and you get more of a tremor, that's pretty common. And there are medicines that can kind of help those. But Parkinson's has kind of got a different look to the tremor. The pill rolling tremors.
More of a resting tremor.
Yeah, and a lot of times patients like to hear about cogwheel rigidity and what that looks like in a Parkinson's evaluation. So,
yeah. And of course, with Parkinson's, you've got more of the stone faces, maybe a shuffle gait, and
Some swallowing difficulties,
Yeah.
some speech changes.
Yeah.
So there's other characteristics. Now, sometimes it just starts with a tremor that may or may not look like an intention tremor or not. So sometimes you just kind of have to follow them along and see if those other things develop. But
are there some medications or anything that could help an essential tremor, this tremor with doing something?
yeah, we have, there's a beta blocker, propranolol, that we prescribe. There's a few other medications that are fairly benign for it. I usually start with propranolol because it's it's a safe medication. There's really not a lot of side effects. It doesn't interact with a lot of things, and it's cheap, and it's an old drug, and it still works. So that's where you start.
Absolutely.
and that's what I do. And if it gets worse or something, then I usually ask the neurologist just to be sure if
Right.
they're going to go to more high-test medicine on it, that we know what we're dealing with.
Right.
Yeah. This person said they've been taking grape juice for arthritis, and it seems to be helping her out. She's curious if there's any science behind this.
I haven't heard that.
I'm going to bow out a little bit.
But there are several
there are.
things that have some natural anti-inflammatory properties, and maybe grape juice could be one of them, or vinegar, or
Or just eating your berries, which are
Yeah.
highly anti-inflammatory.
Yeah.
You know, your raspberries, your blueberries, your blackberries.
Yeah.
I mean,
and help your bowels too.
yes, yes.
How often should a geriatric patient get their pneumonia vaccine? So it's recommended for everyone starting at age 65.
Yep.
And if you use the latest 20 valent one, I mean, that's done. But otherwise, a lot of times we've still got maybe one at 65 and then the last one at 66. So
there's two of them.
There's a few different
Right.
pneumonia vaccines in the mix right now, and we're kind of in this big transition of what to do if you had them before 65 for other reasons, and which ones do you need after going forward. So everybody's a little bit different, but it's 65 and should be one and done if you do the one or maybe two.
Yeah.
Yeah. And some people younger than that, if they have immunosuppression, obviously, then your physician will have you start them earlier. Your frequency might be different, but
Yeah. And sometimes I've done it, if it's been 10, 15 years, I might update it, but it's hard to, by then they haven't had the newest one anyway.
right,
So,
right.
With summer and being outside more, should we still get an updated COVID booster or wait till the fall? Anyone asked you about that yet?
Well, the latest recommendations are really only over 65. For the 65 and immunocompromised.
But that's the thing, so your patients that just had it in October.
Yeah, so it's 4 months after that is those 65
So we're past that
and
point.
immunocompromised. So yes, you can get it. What's coming in the fall? I don't know yet. I haven't heard.
So would you recommend they get it now or wait till the fall?
So, it really depends on I mean, if they want to get it, I actually have given a couple patients their boosters. Also, if they have people in their households who have a little bit more immunosuppression, I'm highly recommending it for them now with this new recommendation. But I don't know.
Yeah.
I really don't know.
It's there. I diagnosed 2 today, and so for people to think it's gone, it's not gone at all.
And
I've had
still
patients in the hospital lately too. But you know, I guess the bottom line there, you could say, oh, I'm going to wait till the fall like it's a flu shot, but we've had COVID throughout, so we know that it boosts your immunity for a while, and then that starts to fade again. So you could get it boosted now.
Yeah,
and if you choose to wait,
the thing about COVID compared to flu is there's no seasonality to it.
Right.
It's all year round. Whereas flu, I mean, there's some seasonality to it. So that's why we do a fall vaccine kind of every year. With COVID, I mean, it's not a bad idea to get the booster.
We'll learn more. There's more to come. I mean, it's
bound to adopt some sort of seasonality at some point. It just hasn't yet. But,
it's still a learn and process, right?
Right. This person, anytime I eat or drink anything, I get watery diarrhea. What could the cause be?
Oh gosh, any number of things, right? They could have just irritable bowel with diarrhea. They could have food allergies. They could have celiac. They could have something going on in their colon. That would be something you should talk to your primary care provider about. If you haven't had a colonoscopy, that would be something to highly consider to make sure it's not an inflammatory disorder. Or it could be a sign of colon cancer because if it's a change. So yeah, I would have a visit with your primary care provider, and then they can do workup depending on your other symptoms, weight loss, all of those things.
Sometimes it is an infection, can get treated and get tested for it.
And then sometimes it's benign, and we do over-the-counter therapies for it, like Metamucil and Citrusol and things like that.
But they might need a colonoscopy, and sometimes a biopsy shows it's a type of colitis, and we can get that treated with a steroid, and they're good.
Right,
so.
right.
Yeah. My sciatic nerve pain causes numbness in my leg and foot. Can you explain what a cortisone shot does? Does it treat the problem or just treat the symptoms?
Well, you got to decide where the problem is first, and then a lot of times once you find the problem, that's where you put the cortisone shot, and hopefully that takes care of the issue. But a lot of times with sciatica, we'll use oral medicines to start with just to see if we can get things quieted down and make people comfortable. And depending on how that works, then you move on to therapy and imaging, and you want to find the spot if you can. So you would hope in the end you'd get to the shot where the problem arises. But it might be a mechanical thing that an injection won't take care of and you need surgery for. So
I think sometimes patients feel like, well, there's something going on, I need surgery to fix it. It's like, why would therapy or why would a shot help? But they can help calm down the inflammation, then there's less.
And that could actually just take away your symptoms, because it's the swelling a lot of times that puts pressure on that nerve. So if we can get rid of that swelling with either an oral therapy or a steroid shot there, and then doing therapy to strengthen those areas so it doesn't come back. We try not to do, years ago, everybody almost would have surgery, right? And now it's less and less of a treatment plan because there's other complications from surgery. It may not make it better. And when you look at the long-term effects of surgery versus, conservative management, sometimes they end up being the same outcome.
The longer I do this job, the more impressed I am with physical therapy.
Yeah.
Who'd have figured that would do as much good as it does do?
Right.
Yeah, and I think we're blessed to work with some great physical therapists, but I think that's come a long ways too, and in the ways they can help people. What can be done for peripheral neuralgia?
It depends on the cause. You know, that's another. We're kind of in that same leg pain question from earlier a little bit. You know, what is it? What's it coming from? If there is a cause that you can find, but you know, if it's from a back issue, then you can take care of that. If it's diabetes, you can take care of that. If it's usually there's other nerve pinches that can go on in different areas, whether it's in the groin or the lateral leg or something, where you can treat those with some medicines. But that's a pretty long list of possibilities when you say peripheral neuralgia.
Yeah.
Right. And you know, like I said, there can be some medications that helps, but even if it is caused from diabetes, you want to get the diabetes under control, but then take some medications to help. About 20 years ago, a caller was told she had celiac disease and has been going gluten-free since. The caller is curious how she could test if she still has the disease.
So we do have a blood screening test. Maybe reliable, maybe not, but I mean, it's a screening test. I think if you've already gone through the process, and typically celiac diagnoses, colonoscopy, biopsies. If that you're celiac.
The one thing you want to make sure, if you're going to do the test, the blood test again, you just don't want to do it gluten-free. I mean, you got to challenge yourself.
You might need to challenge.
You got to challenge yourself and then
That's
go at
true.
it again.
But then if you reintroduce gluten in your diet and you don't feel well,
You've got
it doesn't matter what any of the tests
exactly.
say.
Right.
Exactly.
Yeah, and there's gluten sensitivity sometimes where the tests don't show anything, but obviously I don't feel well when I have gluten, so might as well.
And I've had patients who, they eat gluten, they get those symptoms, we do their celiac screen, it's normal. I'm like, well, just stay clear of the gluten if that makes you feel better, because you probably have more sensitivity. So, is it bad to be gluten-free? No. Especially if it makes you feel better.
In this last 30 seconds, I just want to thank you both for coming on the show and stepping up and Ask Anything can be scary, but I knew family docs were the people to have on, that you guys are asked this stuff every day, all the time, and I know you care about your patients, and we appreciate taking the time to be here, so thank you.
Thanks for having me.
I'm sorry if we didn't get to everyone's questions this evening. Our prize winner, the winner of our prize tonight is Betty from Aberdeen. Thank you, Betty, for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be right back after this.
Listen today to the Prairie Doc podcast, a weekly show hosted by Laura Ellsworth, as she talks with medical professionals, takes questions, and walks us through important health topics affecting those in our communities. Search for Prairie Doc on SoundCloud, Apple Podcasts, Stitcher, and wherever you find your favorite podcast today.
Imagine how just over 100 years ago, nearly 1/3 of people in the Great Lakes and upper Midwest regions walked around with a goiter on their neck. A goiter is a lump on the throat, which could be as big as an orange, a grapefruit, or larger. Actually, an enlargement of the thyroid gland. A goiter can come from an overactive thyroid gland, an underactive thyroid gland, or an autoimmune condition. But in the United States before the 1920s, the reason was almost always a deficiency of iodine. Iodine is required for making thyroid hormones. In addition to having a goiter, those with iodine deficiency may be fatigued, slow-moving, or have poor concentration. Iodine is even more important for brain development for a fetus during pregnancy and for the growing brains in young children. Iodine deficiency can cause fewer IQ points. The archaic term cretinism refers to iodine deficiency syndrome from birth, and affected people are small, mentally slow, and may have an enlarged tongue and thickened skin, among other ailments. Likely 50 million people suffer from iodine-deficient brain damage worldwide still today. Iodine is a trace element on the Earth's crust, but factors like glaciers and flooding have caused it to even be more scarce in landlocked areas and more prevalent around coastal areas. In the coastal areas, the iodine makes its way through the food chain. In the goiter belt, the upper Midwest and upper Great Lakes regions of the United States, and in Switzerland, goiters were common due to the lack of iodine in the diet. The ancient Chinese knew ingesting seaweed could shrink a goiter. In the early 1800s, a Swiss physician observed ingesting iodine could treat the goiters of his patients. As with many things, it often takes a war to cause change. In World War I, a Michigan physician observed that over 30% of recruits had a goiter, and for many of them, it was big enough to disqualify them from the military. This finally got people's attention. In 1917, U.S. physician Dr. David Marine convinced the Akron, Ohio School Board to allow him to perform a study with iodine supplementation. The schoolgirls who received iodine had significantly fewer cases of goiter than the girls who did not. Dr. David Cowie, who founded the pediatrics department at the University of Michigan, proposed the U.S. adopt the Swiss practice of adding iodine to common table salt. It took effort, but thankfully the salt companies adopted the practice, and still today we have a cheap, common remedy to help prevent goiter and iodine deficiency throughout the United States. Thank you to our guests, Dr. Eischens and Dr. Boyens, for volunteering their time to help us learn. If you would like to see and hear more episodes, please like and follow us on Facebook and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever you get your podcasts. As we finish our last live episode this season, we have 2 more episodes on May 11th and May 18th with valuable information just for you. Please tune in to learn more about blood cancers and organ transplants. From all of us here at On Call with Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people. Blood cells fight infection, carry oxygen throughout your body, and control bleeding. What happens when things go awry? Understanding your complete blood count, hematologic cancers. Next time, On Call with the Prairie Doc.
Having access to trusted public health information is essential for thriving communities across South Dakota. As Americans, we all value the ability to make appropriate decisions about our health care. To do so, we need access to quality information from reliable sources. The Prairie Docs and their guests have been providing such information based on science and built on trust for the past 20 seasons. Hello, I'm Stephanie Herseth-Sandlin, and I serve on the Volunteer Board of Directors for the Healing Words Foundation, a 501c3 founded by Rick and Joni Holm. As we move into our 21st season of Prairie Doc programming, board members, doctors, and volunteers continue to follow our mission to enhance health and diminish suffering by communicating useful information based on honest science and provided in a respectful and compassionate manner. Your donation to support Prairie Doc programming makes an extraordinary difference in fulfilling this important mission. Your generosity helps strengthen the Healing Words Foundation and expand the reach of trusted healthcare providers to share important health information that empowers individuals and families to make the decisions that are right for them. Donations from individuals comprise 50% of the funds generated by the foundation to support Prairie Doc programming, and gifts of any size serve to enhance its impact. Please consider a personal or corporate gift today. Just go to prairiedoc.org to donate. Should you prefer not to donate online, please reach out to us by email, and Foundation staff will follow up with you about a pledge. Many thanks for supporting the mission of the Healing Words Foundation and Prairie Doc programming in South Dakota and throughout our region.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello, possibility. Hello, healthy.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
South Dakota Academy of Family Physicians,
Avera Heart Hospital,
First Bank and Trust,
Dakota Allergy and Asthma,
Vance Thompson Vision,
Monument Health,
Black Hills Medical Society,
Brookings, Madison, Flandreau District Medical Society,
Pierre District Medical Society,
Sioux Falls District Medical Society,
Yankton District Medical Society,
Orthopedic Institute,
Lake Poncet Sailing Academy,
Aberdeen Asthma and Allergy,
Dakota Bank,
South Dakota American College of Physicians,
and Swiftel Communications.